Let me just say,
You can sit up here.
But has anyone seen that phone?
wait a minute.
Anyone seen what?
There it is. The phone. Oh, we're good.
I'd like to go ahead and say something. We see a lot of people signing up. We've got 7 bills on today. We're going to do this and finish before 5:30 so we can get this to the clerk's office so it can be first read tomorrow and on the first supplemental calendar on Monday. If you don't make that first supplemental calendar, you may not make it at all because we've got a lot of bills coming in from a lot of committees. So having said that, each bill will have a presenter and they can have 2 to 3 people speaking, but we're not going to be able to allow everybody to speak on every bill because we will not finish in the time that we've got, okay? So I would say the sponsors of the bill sort of figure out who you want and, obviously we're going to hear from the opposite side and we'll just choose off the list and try to be fair to everyone, okay? We've still got 1, 2, 3. We got enough now, don't we? Okay, we're going to go ahead and open the meeting. We've got enough folks here to hear the bills. We're going to start off with 493, Representative Hatchett. Which mic are you? Okay.
Do you mind if I just present from right here? Okay, House Bill 493, LC 339401 is a bill that will help our nurses that work for Veterans Administration hospitals in our state. I've had a constituent bring this to me that she actually works there. She usually gets her continuing ed at different places, but the last year she wasn't able to and was wanting to use one of the exceptions in option 4 that they can do, but Veterans Administrations are not listed as a place you can work for 500 hours and have that exempt status to get your CE. And the reason is they are not a Georgia licensed entity. They're federally licensed. So I'm bringing this in hopes that that can be added to the option 4 to actually allow Veterans Administrations or facilities operated exclusively by the federal government or any of its agencies as an exemption.
Any questions from the committee? I
The-
don't have to sign that sheet. Do you have someone here that's speaking to this? Mr. Chairman?
I don't see one.
See one? Okay.
No, I was hoping that somebody here was, they were all here to talk about it.
Yeah.
Just kidding.
All right. Do I hear a motion?
Move to pass.
Second? All those in favor say aye.
Aye.
All those against? Mr. Chairman, you got your bill. Thank you.
Thank you, sir.
If you want to take a sheet from my assistant over here, have I signed those? You have my signature? Throw some over in. For all those with legislation, I'm going to sign these, and you can take one that when you pass, if your bill passes, and we'll get this on a quick turnaround. All right. Let's now hear 455, Representative LaHood.
Thank you. Thanks, Mr. Chairman. In committee, House Bill 455 is a workforce bill for medical healthcare professionals, physicians, pharmacists, nurses, other registered healthcare, professions. And what it does is it creates a safe place, safe haven for these healthcare workers to seek certain types of treatment to combat career fatigue, burnout, which we're seeing all across the workforce, namely healthcare. And this gives them a safe place to seek treatment, whether it's counseling, certain types of therapy, and it would make the treatment non-discoverable, so that it doesn't put them in jeopardy of losing their license. And I've got Bethany here with MAG that can help me answer questions, 'cause I'm sure there will be some.
Would you like to make a statement?
Sure. I'm Bethany Scherer with the Medical Association of Georgia. We have physicians all across the state. This was brought to us last year. We actually made it through the House, made it most of the way through the Senate, and just didn't make it all the way across the finish line. We did work with the other side, and I don't believe we had any opposition last year, so none that I ever heard. And, really the goal of this is to get healthcare professionals, including physicians, the care they need on the front end, so that hopefully we can avoid the things that can go wrong when a physician or other healthcare worker is feeling, the effects of that burnout and fatigue. And that's, become a huge issue as we've gone into COVID. For the attorneys around, we have something very similar through the State Bar Association. So, thank you.
Okay, are there any questions? Thank you. Are there any questions? Hearing none, do I hear a motion? Second. All those in favor say aye. Aye. All those opposed? Congratulations, Mr. Chairman. You have your bill. Okay, up next, Representative Jaspers, House Bill 546.
Catch my. I'm a witness too.
Which one are you on? Okay.
There we go. Thank you, Mr. Chairman. As I catch our breath, we're running up the stairs. I went to the other building, doggone it. I'm sorry. But, needed the exercise, didn't I?
Sorry about that.
We have a sub to House Bill 546, LC 9469S. Should have in your folder. And, people always ask me, Chairman, why I'm always working with pharmacy bills, and that's just an honor to my dad, who was a pharmacist back in the old days when they called them druggists. And, and I've always kind of been open to whatever the association or would like to do. If you look at the bill, it's a pretty simple bill. This is the authorizing pharmacists to adapt prescriptions in limited circumstances. You look through there, it authorizes the pharmacist to change the quantity of a prescription. There's a lot of ifs. If the prescribed quantity or package is not commercially available. That happened to me 2 weeks ago on a pill, just because of shortages and supply chain things. And two, the change in quantity is related to the change in dosage form, strength, or therapeutic interchange that's commonly known with them. Already in law is allowing the dispense of up to 90 days. Chairman, in my medications, all my pharmacies moved all mine except one to a 90-day medication. And then authorizes the pharmacist to change the dosage form if it's in the best interest of the patient and the prescribers. The physician's direction are also modified. And the example I have here is just the patient went to the ER, received a prescription for ceftriaxone, an antibiotic at 500 milligrams. One capsule twice a day, but there's a drug shortage of the 500, and the pharmacist switches it to a 250, 2 capsules twice a day. And that, if I'm not, one last part, it also authorizes the pharmacist to complete missing information on a prescription if there's evidence to support that change. And that's, in there, if they've had a long-standing prescription, to just go ahead and fill it out if there happens to be an absence of information. And that's just dudes just trying to get a hold of each other back and forth.
All right.
That's the bill.
Any questions? Go ahead.
Just want to thank you. maintenance medication, high blood pressure, diabetes, stuff, is it spelled out in code anywhere what would that would entail? Is there
I would
anything you have to
not
take on a
know.
reoccurring
Bethany,
basis?
do you? I mean, or
I don't.
Vincent, would you come? Bethany,
Miss.
would you go to the mic, please?
I'm not aware, I'm Bethany Scher again. I'm not aware of a definition of maintenance medication, but it is used other times in our code section. We use it in prior authorization code as well.
I don't have a problem with it. Proper
Insurance
time, I'd
code.
like to make a motion. I just curious.
Well, we have Melissa Ribo.
Yes.
We have Melissa Ribo to speak.
I just wanted to say I'm Melissa Ribel with the VP. I'm the VP of Public Policy for Georgia Pharmacy Association. I wanted to thank Chairman Jaspers for bringing this legislation. I think this will ease a lot of the bottleneck situations on the sides of the pharmacy as well as the physician. You know, right now pharmacists, they have to call for everything, even if it's a common sense, seems like a common sense thing to change. They have to call and get doctor's authorizations, and a lot of times patients leave the pharmacy without their medication because the pharmacist has to wait on a callback. So we're in support of this bill, and thank you, Chairman Jaspers, again, and I ask for your favorable support as well, committee members. Thank you.
Thank you. I think that's all we have speaking to this bill. Is that correct? Is anyone else here to speak to the bill? Okay. Do I hear a motion? Do pass. A second. All those in favor say aye.
Aye.
All those opposed? Congratulations, you have
Thank you,
your
Mr.
bill.
Chairman. Thank you,
All
committee.
right. Oh, give me another one. Yep. All right. Okay, let's do House Bill 343, Representative Newton. And you can do it from there.
Thank you, Mr. Chairman. Bring back before you, we did ask this to be recommitted to rules so we can make some improvements that were a result of some of the feedback we've gotten. House Bill 343, I'm using LC number 339467S is the version that we're working on. This is the bill to lower patients' out-of-pocket prescription costs at the point of sale in an effort to make sure that compliance improves and that patient affordability improves and hopefully complications and unnecessary ER visits and hospitalizations decrease. So it's an effort to make that better for patients. There was a concern, we had 80% of the money of the rebated amount. Once again, there's a list price that's paid, and then there's a rebate, which is like a contractual discount. So you end up with a true price somewhere down below that. We asked that in the earlier version, we asked for 80% of that to be credited to the patient so that there, for example, if there was a $1,000 payment for a medicine for a month on a new medicine that was life-saving and the rebate was $500, this would have required the PBM to calculate the patient's 20%, for example, at on the $600 rather than on the $1,000 initial list price that was paid, but on the true price. Because there was a concern about potential effect on premiums for all the other people who maybe don't use medications, we did a little more research on it, and we did find a couple of things and made a couple of changes to the bill because of that. California actually a few years back had a Assembly Bill 933 that did the exact same thing, but they used a 90% credit to the patient for the rebate amount. Once again, allowed about a 10% for admin and overhead and profit for the PBM. In their particular figure, and I can get the 48-page document to whoever needs it, but it looked like it did affect premiums. So people were correct that it affected premiums. It affected premiums 0.1%. So 1/10%. If you use, for example, the $950 or so that is paid monthly for all of us on state health benefit, teachers and all, that would have been a 95 cent a month change. That's at a 90% figure. But out of abundance of caution, we've added two things to the bill, or changed two things. We've lowered our 80% of the credit down to 50% to make sure that 50% or more of this rebate amount that's retained by the PBM can go toward premium reductions. So number one, we should be well below this 1/10% that is the estimate based on, I believe this is close to 13 million patients that are in another state. And by the way, even though we don't mimic everything California does by any means here in Georgia, but when it comes to health care and high blood pressure and serious illnesses, multiple sclerosis and other things, pharmaceutical usage and the benefits are pretty much the same in our state. So we believe the number to be between 0.1 and 0.3%. If you were given 90% back through, we think by going down to 50%, we know it can be under 0.1%. Out of an abundance of caution, we also called for a reporting, not specific rebates, but an aggregate of rebates at the end of the year, so that if there was a concern or we did feel this was leading us in a direction where premiums might in the future have to be increased, by having some information at the end of the year, after the end of the plan year, that would give us two options, especially if we get it by February 15th or so. It would give us opportunity if, for some reason, Georgia was dramatically different in our pharmacy usage, and it was above 0.1%, we would have an option to adjust the bill in the future. This does take a year or two to come into play. We want to give the insurers plenty of time to ramp up for it, to get ready for open enrollment in a year. I know that takes months to get prepared to offer plans to patients, both individuals and small groups. Once again, we still have the two times in the bill that it makes clear this does not apply to large self-funded plans that are governed by ERISA, which is the federal oversight. These are only plans that are governed by the Department of Insurance. Department of Insurance is always telling insurers what to do. They tell them how much bonding or how much capital they need to put aside. They tell them what things to cover, mammography, PSA, whatever preventive stuff. So insurance companies don't like to be told what to do, but really and truly that's part of the role of the Department of Insurance, is to designate what in Georgia we would like our patients to have. This is a bill that we think will have minimal or maybe no impact on premiums, especially if you get fewer complications. You may have a little higher spend on the pharmacy side, but less on the medical complication side. So we don't think it'll have much effect. It'll be close to this 0.1% at worst that we saw in California. We've got the bill. So that's the bill, sir. We've just dropped what was already passed by this committee from 80% down to 50%. Out of an abundance of caution, along with the reporting at the end, to make sure that we can, if there was an alleged higher premium need, we would be able to correct it promptly. Glad to answer any questions, sir.
Any questions from the committee? Okay. This bill has been recommitted to this committee, so we're not hearing any more testimony today. Do I hear a motion on this bill? Second?
Second.
All those in favor say aye.
Aye.
All those opposed? Congratulations, you have your bill.
Thank you, sir.
Okay, we're moving along a little bit better time than I expected we would, so we're going to hear a little more. We're going to hear a little more on. I know you want to go home. We're going to hear a little bit on one that was tabled. I hear a motion to take 441 off the table.
I move we take 441 off the table.
Okay, thank you. All right, on 441, we're still going to have some guardrails. Teresa from the, the author. Representative Dempsey, would you like to approach? Yeah, either way, either one place you want to go.
Thank you so much, Mr. Chairman and members of the committees. I want to thank you all for taking a moment, maybe a little more than a moment actually today, to pause and give this measure another opportunity. So we're once again looking at House Bill 441. The substitute should be in your packet. It's LC 52029-0S. This will authorize and regulate the practice of teledentistry in Georgia by Georgia licensed oral health care team members. The bill works with the current general supervision law for hygienists and expanded duties dental assistants to work outside, physically outside, of a private practice setting in both safety net settings established in 2017 and other locations. The bill will help to create a network of dentists within Georgia that allows providers to share workforce and gives Georgians better access to very important oral health care. The premise of this bill is that while teledentistry encounters are a useful tool for triage and consultation purposes, as well as expansion of access, dentistry is still an inherently tactile practice. If there is a problem, ultimately the patient still has to see a dentist to receive treatment. From a patient safety perspective, this bill ensures that all patients know the identity of their dentist and how to get help, whether that is from the Board of Dentistry or even a private attorney, if the dentist is unresponsive to their patient's concerns or the patient is harmed by the dentist or their auxiliary staff. Since we were last here, there have been some negotiations to improve the bill, and Teresa Robertson was involved in that, so I'd like to give her some time to explain those changes to you.
Thank you, Mr. Chairman, members of the committee. I'm Teresa Garcia Robertson. I represent the Georgia Dental Association. There are 4 changes that have happened in coordination with the Department of Health, and we just wanted to make sure that everything that the Department of Health was currently doing with teledentistry was going to remain intact. So if you'll look at lines 120 to 132, the authorizing dentist shall perform the initial consultation with the patient through an in-person clinical examination of the patient or through synchronous real-time communication, and then added is or asynchronous communication involving the authorizing dentist, the applicable dental auxiliary permitted under this code section, and the patient, and that would apply to the safety net settings. In lines 143 through 148, we just added that the informed consent shall be obtained from the patient or the parent or guardian if the patient is a minor. And then in lines 155 to 157, section B, the referred dentist shall, instead of be available to, it says the referred dentist shall accept a referral to treat all dental emergencies. And then in lines 163 to 165, section C, talking about liability insurance, we just added that this provision shall not apply to an entity covered under sovereign immunity, which would apply specifically to the Department of Health, which is covered by the state.
Okay. I know that you want to have one person speak to this.
Yes,
But
sir.
before that, I'd like to give the opportunity to Ethan James to come up and present and bring whoever you'd like with you and recognize whoever you want. Oh, I'm sorry. Excuse me, just a minute. There was a question. Someone had a question? I don't know. Okay. All right. Ethan, you can sit back down. I'm sorry, I didn't see the line.
Thank you, Mr. Chairman, members of the committee. Can y'all hear me okay? I'm going to
Yeah.
lean in just a little bit here to ensure that this mic picks it up. I represent the Georgia Dental Hygienists Association, and I want to thank you for the opportunity to present again. I know you heard our testimony last week, most of you who were here. I'm joined today by Wendy Blonde. She is a dental hygienist, and she's going to talk a little bit about the services she provides. We're still working off the original draft. We have not seen the substitute to the bill. I was under the impression that Section 2 had been stricken from the new substitute. Is that true?
Was that what you
I know
and
I'm
the
not supposed to be
GDA
asking questions, but
Yeah, is that what you and the GDA discussed?
I had an indication from,
I was told that there was not an agreement.
okay. I got a note, I believe, this week that Section 2 was coming out. If it's not, we still have grave concerns about Section 2 being in there. But perhaps that does speak to the lack of a negotiation process with the Dental Association and not having us at the table to craft this bill, which is, again, of grave concern. The Georgia Dental Hygienists Association does support teledentistry, but not as presented in this bill. We think this is not the proper way to do it. It is not the way it was done during the pandemic when teledentistry worked so well. I do have some handouts that I'd be willing to share with y'all if you wanted to come see me about them, talking about the differences between dental hygienists and dental assistants and their educational differences and their licensure differences, meaning they're not licensed dental assistants. They are not licensed. They're not regulated. There are no enforcement mechanisms to the Board of Dentistry for dental assistants. We don't believe that they should be treated similarly in this legislation. Talking about a dental auxiliary being a dental hygienist or a dental assistant. The original draft of the bill did go on to say that dental hygienists have to have certain educational and certification requirements, ongoing education, and licensure, and they also have to maintain professional liability insurance. But that is not true for dental assistants, yet they're still treated the same in HB 441, so far as we saw with the original draft. Thank you, sir. With that, let me turn it over to Ms. Blonde. She's going to tell you a little bit about how she does business, and I'll take a look at this while she does that, and she has some images to share with you all as well. Thank you. Wendy?
Thank you, Chairman, for this opportunity. As he said, my name is Wendy Blonde, and I do utilize House Bill 154 and provide on-site dental cleanings for primarily our seniors and our residents with physical disabilities that cannot make it to a private practice setting. I've got some images here that people always ask me what kind of equipment I use. It's portable equipment, so you can see everything that I have. And I do bring this equipment into the community and provide this service for them, which I really specialize in for people with dementia and Alzheimer's that would have a very difficult time leaving the community. And so bringing this to them makes a big difference. The name of the company is Marion Mobile Dental. I get asked all the time if I'm Marion, and no, I didn't want to name it after myself, but instead I kind of did this name after somebody else. And that person is Mother Mary of Christ. This is very much a faith-based journey for me. And I did that because she said yes to God's plan for her. And I feel like this is my yes to God's plan for me. And she was given something very special to cherish and to protect and to take care of. And I see each one of my patients as exactly that. I look at a little image on the same note. I look at a little image of Mother Teresa every day. It's on my rearview mirror. And Mother Teresa took care of the poorest of the poor. And that is what I'm trying to do. If you can change it. The person who we changed House Bill 154 for was Moselle. She was the catalyst for 154. Moselle ended up dying with a dirty mouth. And she was in Augusta, Georgia. And she was a family friend. And she's the reason that I do what I do. I couldn't help her, but I'm not going to let anybody else have that same condition. Now, you can tell by that image, a hygienist is not all that she needed. And I don't do this alone, but a hygienist could have helped her tremendously. And I help my people tremendously. And one of the best things I do is I am a triage. I identify small problems before they become big problems. There's almost $500 million spent in Georgia in emergency rooms for dental. If dental hygienists were being properly utilized, we're going to help refer small cavities, get those filled, working with dentists so that we're not seeing that influx in the emergency room. So 154 was sufficient. It has us working. I'd like to also present Precious Jones. She operates Senior Smiles. Between the two of us, we service about 60 community homes across the North Georgia area. I service Canton to Commerce and down to Lilburn, Ella J down into Atlanta, and she services from Canton over to Ackworth and going that direction from Atlanta. So between the two hygienists you see in this room, we are servicing 60 plus communities that were not serviced before in this way. We do work with dentists. We make referrals. We don't expect to handle everything ourselves. And that's the beauty that teledentistry could offer if it was done correctly. The problem is the way that this bill is written in front of you wouldn't do that. In fact, it would probably shut down both of our services. So this bill, teledentistry could be a reasonable solution that can take us from being sufficient to being optimal. But the bill in front of you really needs kind of open heart surgery. So it's going to take a lot of work to get it to where it can be a new heartbeat for our services.
Thank you. Thank you. Any questions? Representative Parsons.
Yeah, I wanted to say I appreciate you coming and testifying on this. It's about 8 pages, I think it is, of brand new language. Everything's underlined, so as far as I can tell, it's brand new language. It's a lot of new language for a bill. But on lines 52 through 58, there is a definition here. It says means, which I take that to mean it's a definition of teledentistry. And I'm looking through it, and to me, it's meaningless. But I'm just wondering, did anyone talk to y'all about this definition? Or I'm wondering where it even came from. But has anybody discussed this? And it's referred to, even though it's a meaningless definition, it's referred to, pretty much throughout the bill. I'm just wondering, has anybody talked to y'all about that to try to come up with a good definition of teledentistry?
Chairman Parsons, the Georgia Dental Hygienists Association is a new client for me this year. I can't say that I've been part of any of the conversations regarding the construction of this bill. However, I can tell you that GDHA did have a original draft of something partially similar to this legislation from a couple of years ago. So I know this has been in the works for a while, but I can't honestly say that there have been formal discussions. I don't know how it was constructed.
Okay. Well, I appreciate it. It reminds me, this paragraph reminds me of a few years ago. I think it was one of the hospitals, or I'm not sure who it was, came and testified, and they talked about their telemedicine. And what a great job. It turned out their telemedicine, what it was picking up a telephone and talking to somebody. Well, I mean, if you want to call it that, but that's not a very good definition to me. And this right here, to me, it does nothing. I mean, the very last line, the interaction shall not be considered the equivalent of an in-person clinical examination. Well, then why even have it? I mean, why even have it in there if that's the case? I know it's not yours. I'm just kind of, that was my question, and you answered it. I appreciate it.
I think, unfortunately, I think this is not all teledentistry could be. I think the effort that the dental hygienist has been making and trying to educate people on what teledentistry could be is a much better approach. And again, as written, as introduced, and as currently written, GDHA would stand in opposition to this bill.
I mean, I'm sorry. It's something that could be really something, and it needs work. It needs to people to come together and create something, not this.
I agree with you, sir. I also have a letter here from a dentist who is employed by a large educational healthcare research institute in the metro Atlanta area. And he stands in opposition to HB 441 as well. And I can share that with any committee members who are interested.
Representative Newton.
Thank you, Chairman, and thank you for your work and your ministry. I think you're bringing some much-needed care to people who often get forgotten, and I appreciate that. You're a challenge to all of us. I am curious what in the bill, first off, Chairman Parsons' question, teledentistry really looks like it mimics a lot of the language I've seen in healthcare and telemedicine, and in a lot of this asynchronous, synchronous, real-time, not a clinical examination. We are all gradually getting into telemedicine. We were doing it in some areas, remote schools before COVID. COVID lowered the bar from a HIPAA-compliant video to even a telephone call got to count for 2 or 3 years now. So it is true that telemedicine and in this case teledentistry did get changed a good bit by the pandemic health emergency. Is there a particular line in here that, because it seems like you're working along with a dentist now, why would a dentist not be able to authorize you, along with maybe some additional look at the pictures you showed of giving a recommendation? I really love the fact that the language in here says the dentist shall be available for emergency care. I'll tell you, that is not what is available when you do a telemedicine visit, which I've been on both ends of them as a patient, and the person was in Miami. So they weren't going to be much help if it turned out I needed an in-person exam like I believe the individual you showed a picture. Would it be good, and aren't you already working with the dentist?
So I am working with a dentist, but the problem with the bill is that it adds a lot of bureaucracy. There's a lot of it filtering through the Board of Dentistry instead of allowing us as professionals to work together like we already can and do. We work with collaborative agreements right now that were set up with House Bill 154. We have a relationship. We have referral systems in place. The dental office I work with has oral surgery. They have endodontics. But also the way that referring dentists work with the authorizing dentist. My authorizing dentist that I work with the most is in Johns Creek, Georgia. When I'm servicing ELIJ, I need to be able to refer with a verbal, not a written on line 41, a verbal to a dentist that's in their area, because my patients are having to pay medical transport to get to the dental office. Their family's taking off work. They don't need to drive 40 plus minutes down to Johns Creek to see my authorizing dentist. We need a simple referral. This one also has that not only will that referral have to be in writing on line 41, it has that I have to submit to the Board of Dentistry about that referral and communicate through the Board of Dentistry these referrals that are taking place within the state. That's the kind of bureaucracy and the red tape that this puts into place that's going to make this so much harder than us just saying, oh, you like Dr. Smith? Let's get you this information to Dr. Smith. We'll get medical transport and we'll get you there and get this care. Now I have to work with the Board of Dentistry, and my doctor that authorizes me and the doctor that's getting it is having to get all of this together for the Board of Dentistry to review. This is bureaucracy in a bad way. Sorry.
Just a quick follow-up. Do you use an electronic health record?
Yes, sir. So
Okay.
we
Those were meant to make it easier. So what used to be a written referral, like on a prescription or a piece of paper, and now you got to find a way to fax it or get it to someone. I had hoped that electronic health records, the beauty of them is you can do stuff in writing, and teledentistry or telemedicine is sometimes 24 hours a day, all hours. It's nice to have an electronic way to communicate, and it does make a written communication much easier. And I think that's probably one of the reasons it's in the bill, is to make sure there's a clean handoff to a responsible dentist. But I appreciate your work. Thank you.
You're welcome.
Okay, Representative Kelly.
Thank you, Mr. Chairman. Just trying to understand the complexity of everything here. Speak to me, and I know at the beginning of your testimony, Ethan, you spoke about Section 2. Explain to me the y'all's position on the legislation, your position without Section 2, and then speak to me about what Section 2 does in y'all's opinion.
Okay, thank you, Representative Kelly. Section 2 would change the scope of practice for a dental assistant. Right now, as you can see, dental assistants are allowed to use a procedure called a rubber cup prophy, which is a prophylaxis. It's a cleaning mechanism for the teeth. It's a polisher. It's a little wheel. I think you put some paste on it. And they're allowed to do it on patients, as it indicates here, with primary dentition. That means baby teeth. Chairman Newton, I think you pointed out last week, baby teeth fall out. So the danger in doing it on baby teeth is lessened. But there is a real danger in damaging an adult tooth using this coronal polishing method, and it has to be done by a trained, licensed, regulated individual. And right now, dental assistants don't fall under that. They are only allowed to use rubber cup prophy on baby teeth. This is a scope of practice change, and we oppose that. The dental hygienists oppose that. If they had taken that section out, I think we would still stand with great concern on this legislation, again, due to other scope of practice changes that are more or less hidden in the bill. It changes direct supervision for a dental assistant, which is the dentist must directly supervise, watch what the dental assistant is doing, to general supervision, which is how dental hygienists operate. they're under general supervision, which means with their license and their regulation and the relationship they have with the dentist trusts the dental hygienist to do their job. And Wendy, I'm going to let you speak to a great phrase that you told me yesterday about the interaction you have with a patient. And that
Excuse
outcome.
me. That goes through the chair,
Oh,
and
sorry.
I'm not recognizing that. We're on a timetable here. We're taking a lot of time.
Yes, sir. Sorry, Mr.
Is that
Chairman.
it? Is that all your questions?
I'll-
No,
I'll yield- I'll yield-
you've got time. No, you've got time.
No, I'll yield, Mr. Chairman.
Okay. All right. All right. Now, we're going to hear from another speaker. Thank y'all.
Thank you, Mr. Chairman.
Let's go here and hear from Dr. Wyman.
Thank you, Mr. Chairman. I want to respond to a number of the questions that were asked because unfortunately, I think a lot of the bill is misunderstood by the Hygiene Association. This bill would not change the relationship between the dentist and the hygienist at all in what it's doing. I happened to be sitting in the room with Chairwoman Cooper when we made in 2017 when we made the general supervision policy together, and that was approved by the Hygiene Association, and nothing is changing in that relationship. We're still like I said, just doing general supervision in all healthcare settings. And I'm very glad that they're doing what they're doing. But I do feel like Chairman Parsons, would you ask your question about you don't think there's a lot happening in a sense? Dentistry is a hands-on profession. There's just so much you can do through teledentistry. It's very useful in a triage situation, but it is not. You're not going to be doing much else unless there's a hands-on. So we want a dentist to be attached to doing teledentistry, so that patient has not just again, when you give somebody a verbal name, that's pretty loose. Then you expect that patient to go find a dentist somewhere, and we all know that doesn't happen at the frequency that we like. And my physician friends that go through the same thing. It's hard, if you don't carry them, a lot of times you have to put them in your car and carry them to the door to make it happen. We feel like that if we have a dentist and it's in 50-mile radius, which is actually the most lenient of most of the rules that are involved anything in the state of Georgia are going to be between 30 if you're to 45 miles away or 30 minutes of travel. So we feel like that this is important to have that dentist, and we feel it's really important for a patient to know that a teledentistry exam is not the same as a hands-on exam. I have the highest quality intraoral cameras. I use them all the time to show patients things that I'm about to do. But I can tell you that the color's not completely true, that I can see a lesion, an oral lesion that I want to send them to for a cancer evaluation, and I can't show it to them. It just shows up, the palate looks pink, and that's all we see. So it's not a foolproof system, but it's a good system. It is good. There's a lot of things that can be done. This Section 2 about the coronal polishing, the dental assistants now go through that can do that, go through a course. And I know about the course because my wife puts it on. She works under the Board of Dentistry. It's in sections, and so there's one section that's just expressly for coronal polishing. And I'm going to tell you, it's just working with children is actually if you can do it with children, you can you're not going to hurt an adult's tooth. It is not a dangerous instrument. It's like your toothbrush. It's a rubber cup. It is rotary. You can buy the same thing over the counter because, the manufacturers of these things said, well, look, everybody's used to seeing that, so we can make one. You can buy them over the counter. But there is a technique to using them properly. It's taught. The people going through this have gone through this and get certified. So this is not a they can't do any of the expanded duties that we do, and almost every dentist wants their assistants to be certified because most of the things that we're utilizing for nowadays, we need an expanded duty assistant. So those assistants would be under the exact same training. They would need to have the proper training, and they're not using any other instruments, so they're not doing deep scaling. They're not doing the part that the hygienist does so well that we appreciate. So these are so we feel like that this is something that can again be just another aid to get more people seen in the state, and we're not. It's there. I mean, there isn't really a danger other than the person doing it falling on the patient, and knocking them out with a headbutt. I mean, so it's really not from the procedure that they're doing. So we feel that, but we do want the patients to know that if they have a teledentistry exam, that shouldn't be it, that they need to see a dentist at some point in time. And just like I would tell somebody with a telemedicine thing, you can get some good information, but I know when I have an exam, there's hands on me. Even with with the internist or the GP, they're listening and touching and doing things and not taking somebody else's word for it. But when you have a broken tooth, it's easy to see, and they can take a picture of it. They can send it over to us, and then we can give them a name and get that person to get some treatment. Thank you.
Representative Kelly.
I'm going to just wait. I thought I had a question. I think I'm going to think on it some more before I ask it.
He answered it for you?
I think I'm going to just keep thinking about it before I ask it.
Okay. Representative Newton.
Just a quick question. I take it from your testimony you think this is a good first step for teledentistry.
I do.
That protects the patient. Do you think it's the last time we'll ever have to visit this?
No, because
we never do have that.
No, because I've been practicing for 47 years, and I've been teaching at the Dental College of Georgia. And when I started dental school, there was no computers in the dental lab. There weren't even calculators. Okay, so you had a slide rule if you want to do something. And now I'm using digital X-rays, digital impressions, things that I just can't imagine, CT scans, all these things are just an intricate part of dentistry. So I don't know what's going to be here in 5 or 10 years, and I would assume that we'll be changing as technology improves and you can do things differently. But I still don't think they're going to work it out where I can reach my hands through a TV and end up in the patient's mouth, 50 miles away.
Thank you. Representative Kelly, you got it now?
I got it now, Mr. Chairman. I've just been trying to, again, wrap my head around all this. I know the majority of the bill it looks like it's a teledentistry bill. Tell me how Section 2 is a teledentistry bill. How does Section 2 apply to teledentistry?
I would say that, it's just another piece that allows at a remote site that could be another procedure that could be done to aid patients. So you'd be able to see some more patients when you're not at a school or a Head Start program or something of that nature. So if you're at a nursing home or whatever, you'd have another piece of the puzzle you could do remotely.
The dental assistant would.
The dental assistant would be in this case.
Okay.
Yeah.
All right. Thank you.
Representative Parsons.
Thanks, Chairman. And thank you, sir. And you make some good points, I think. I'm not a dentist or a doctor, and it's hard for me to, and I'm a patient, as rare as I can possibly be, to tell you the truth, with my dentist. He's a great dentist. But don't you think, though, that it would be better, it's 8 pages of brand new code here, language. Don't you think it'd be better, though, to go back and kind of refine some of these things and work with the dental hygienist and come up with something better and more workable? Because I'm sure that what you want to do is provide the best service and provide it out to as many people as the service can be provided to that you can't get to yourself. As a dentist can't get to yourself. I'm sure that's what you're wanting to do, right? A dentist has his office and he doesn't go to some of these places that the dental hygienists go. So I'm assuming that what you're wanting to do with this is to be able to get as much service provided in as many parts of the state as possible to as many people as possible who need dental care. I mean, is that correct? I'm not trying to set you up. I'm just trying to think that through. I mean, I would think that's what you really want to do.
We do want to, but we thought that we had a vehicle to do it with this bill. And some of the communication problems are, like most of them, are two ways. So they're not just one-sided.
Yeah. I mean,
Because there has been communication, it just,
I guess I'm just asking that. Wouldn't it be better to come up with a better bill that you worked at least in some collaboration with the Dental Hygienists Association with and get their input and just come up with a better bill that would do those things that I just mentioned in a better way and have a better outcome. I mean, I would think that's what you want to do, so to have a better outcome.
we do, but it's, like I said, we've had been working on this for a very long time, and so there's been ample opportunities to have more discussion. And we've done, like I said, we've come a long way in changing the how the dentists have been working with the hygienists. But in this particular instance, we, like I said, we just couldn't come together.
All right, thank you. Appreciate it.
Let me ask Dr. Wyman a question. Did the governor include teledentistry in his emergency orders along with telemedicine?
I don't know that.
The GDA, can you answer that? Yes, they did. Yes, he did. So this has been done through DPH, and that's the reason you had an agreement with DPH on the wording. So actually, it is being done now, has been done, and this language actually has been floating around for 2 or 3 years. So, and I'm trying not to take sides, but I do want to clear that up, that this is not a last-minute Hail Mary. Thank you very much for your testimony. You have a question? Oh, excuse me. There's
Yes.
another question. I'm sorry, I didn't see it.
Thank you, Chairman. Because I think the last time we really went in depth on this particular bill, and I think the biggest thing that I wanted to know, Ms. Robertson, where is she? She came to me and we talked about, my concerns and what I think would probably make things a little bit better in the situation. And the additions, the way they are, is kind of like a great situation of having accountability, which is very important, and responsibility on those added languages. And now that we understand a little bit more that they are going through a training process as far as the dental assistants, that was my biggest concern. That has been talked about, and knowing that they are qualified to do it is just in a different setting. However, it's still something that they can do. I don't think that this bill is going to take the young ladies out of business. As a businessman myself, if you do good business, then you're going to continue to do good business, but this bill won't tear down your business. So my concerns have been met in regarding this bill, and I think they've tried to work hard to make the changes they need to make. So at this time, if it means anything, my concerns have been met, and I can support this bill as written and help everybody involved, because with me is all about the patients, and I think this bill will do that.
Okay, thank you very much. But in complete fairness, we have someone here from Smile Direct Club, and this will be the last person to speak to the bill because we've got another bill, and please make it short because we got another bill that's probably going to take an hour. We're going to open up some testimony. Ray Colas.
Members of the committee, Ray Colas, I'm the Director of Government Affairs for Smile Direct Club, here today to speak in opposition to House Bill 441 as currently written. Now, since the last committee meeting, we worked diligently with the dental hygienists on a compromise that we thought and felt would strike the right balance between access to patient care and quality care, and also being able to maintain patient safety. Now, as we all know, during the recent pandemic highlighted the benefits of telehealth services and the need for access to care, quality care, especially in those communities that are underserved and also in the rural areas. Now, with that in mind, we provided the proponents of the bill with language that would simply eliminate the anti-competitive provisions that had absolutely no clinical justification to even be in the bill. While doing so, we also maintained the ability to provide safe and effective access to quality care as the sponsor of the bill has intended with the introduction of this bill. Unfortunately, our recommendations were rejected, and the language within the bill continues to contain language that is the subject of active litigation, and that is our priority concern with this bill, the way that it's written. I would like to thank the chairman of the committee for allowing me to speak on House Bill 441, and do respectfully ask members of the committee to vote no.
Thank you. All right. That's all the testimony. Do you hear a motion? Do I hear a second? Second. All those in favor say aye. All those against?
No.
3, 4? Okay, let's do a show of hands. All those in favor, raise your right hand.
Are we considering amendments, Mr. Chairman?
No. I'll wait till, I will wait. How many you got?
10.
10. All those against the bill?
Five.
Bill passes. Congratulations, you have your bill. All right. Now, okay. All right, up next, House Bill 445. Representative Mathiak. And you can go from there. You did. You got a lot of those. Let me correct myself. We're not going to spend an hour on this bill. We've got other committees, and I'm holding members here to try to get these bills through. So let's try to do this thing in, good Lord, I don't know, 45 minutes, 50 minutes? Well, maybe it won't take that long. Let's just see.
20.
I tell you what, let me see a show of hands. We're going to have to leave here about 5 o'clock. We're going to lose it. Okay. Can you stay till 5?
No.
Can we stay till 5? You can't? Show of hands who can stay till 5. 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, you got till 5 o'clock. We have to have a quorum to vote your bill. No, you can do it right there.
Mr. Chairman and committee, I bring to you today HB 445. It's a CRNA delivery of anesthesia bill to help some of our rural hospitals in some of the dilemmas that they have. So this is a bill that updates the CRNA statute to reflect the current delivery system of anesthesia in Georgia today. This law has not been updated since 1994, and that's 29 years since the General Assembly has moved with the anesthesiologist to provide direction and responsibility for CNRA work. The bill strikes the terms "under the direction and responsibility of" and replaces that with "pursuant to an order by" a duly licensed physician or podiatrist. Next, the bill codifies a 105-year-old case law holding that when CRNAs deliver anesthesia, the CRNA is a practicing nurse. In short, the case law holds that when the nurse delivers anesthesia, the nurses practicing nursing. When the physician delivers anesthesia, they are practicing medicine within their scopes of practices. What the problem that this bill addresses is last year, Governor Kemp created the Healthcare Workforce Commission, excuse me, to examine how we could address healthcare staffing challenges throughout Georgia, especially in the rural area. The commission was comprised of physicians, nurses, administrators, educators, and other healthcare providers. In December, the commission issued recommendations, including this one under the heading, Maximizing Our Current Workforce. Why do we need this change? Everybody's gotten some handouts, and one of the handouts that you have has the hospitals and organizations. It's the Georgia Association of Nurse Anesthetists. It looks like this. It kind of gives you a pretty extensive list of organizations that are supporting this measure. The letter reflects the recruitment problem, especially in rural Georgia, that the Governor's Workforce Commission identified. The letters convey the same message that this is a law that implements to their ability to recruit and retain surgeons for their hospitals. First of all, the term direction is a misnomer because the Governor's Commission reported identified to the surgeon is not trained in the delivery of anesthesia. The surgeon is providing the surgeon is not providing any real direction, as the term is widely understood to the CRNA about to administer the anesthesia. Second, what we've learned is the physician recruitment efforts, surgeon groups that are considering coming to Georgia balk at having their doctors be responsible for the actions of the CNRA. The letters from my district clearly describe that, or from all these districts describe. Many lawyers and the physician groups see the term responsible and think liable, and therefore don't come to Georgia. This legislation captures the actual involvement of a physician by expressing that the anesthesia can only be administered upon an order from a duly licensed physician or podiatrist. No anesthesia is given to a patient until the physician says so. This is not a scope issue because if this bill becomes law, the CRNA will not be able to do anything new that they cannot do now. Despite what you've heard from the opponents, this bill does not bring CRNAs or the delivery of anesthesia out from under the medical board. CNRAs are not under the jurisdiction of that board today. They're under the nursing board. The delivery of anesthesia by the CNRA is not a delegated activity. CRNAs in Georgia do not have a DEA number and are not seeking that prescribing privilege. This bill does not mandate anything. The model is used by healthcare facilities for anesthesia delivery will remain subject to the bylaws of each facility. 30 states allow for CNRAs to practice in this manner. What we were truly trying to accomplish here was to help with some of the rural hospitals. What I'd like to do next, Mr. Chairman, if we can.
Yeah.
If I could call up Megan Brass and
Yes.
have her testify and help me answer any questions, because she's the CNRA.
Come on up, Megan. Chairman Newton has got a question.
Thank you. And
Thank you for your, I enjoy working with CRNAs. We do that in the trauma center
Yes, sir.
that I work in as well. And I did notice there was a list of all these hospitals and really a lot of surgery centers. Those are all using CRNAs now, right? With the,
It's my understanding, yes.
so they all are working under the current system where there is a team approach to anesthesia where the surgeon or the proceduralist or the spine surgeon is working with a CRNA now with some responsibility. Really, I would probably call it, as you described, joint responsibility because they, the CRNA knows the medication doses and monitoring that side. The surgeon, though, is involved in the, for example, the safety of a particular ASA or anesthesia society classification of a patient or something. So they're all doing that right now under Georgia's current law. Is that correct?
Yes.
And if the second thing on line 16, I'm curious if it's not under the medical board now, if that's the report, why would you need to say that it's nursing? I mean, why do we need the change if it's not a scope, if it's not a coming out from under it, why would we have to have new language pointing out that it's different or changing it?
Well, because in the rural areas, we don't always have an anesthesiologist. And these facilities utilize the CRNAs now. And what I'm trying to show you is that there is safety there. And in the rural areas, they're not going to be doing major surgeries like heart transplants and things of that nature, those types of surgeries. Those would quite honestly go to a larger facility. But what we're trying to do, again, is facilitate for rural areas so the CRNAs can function with a surgeon. And being able to recruit and attract the surgeon.
Thank you.
Yes, sir. Would you like my testimony or would you like a remark? Okay, perfect. Yep. So I'm Megan Brass. I'm a certified registered nurse anesthetist. I've been practicing here in Georgia in a mixed variety of settings, urban and suburban, and very rural. I also represent about 1,600 CRNAs that are practicing here in Georgia today. I think you guys have probably seen this mag alert. And going to your question as to why we need to remind people that we are practicing the art of nursing and not medicine as nurse anesthetists, just to clear the air there. First thing, CRNAs have been practicing anesthesia now for about 29 years here in Georgia without the supervision of an anesthesiologist. Secondly, CRNAs are not governed, nor have we ever been governed by the Board of Medicine because, again, it is the practice of nursing. Just similar to midwifery, when a midwife delivers a baby, it's the practice of nursing, and when an obstetrician does it, it is the practice of medicine. Third, the bill will not establish independent practice. Independent practice would require a DEA number, which I do not have, nor do I want, nor am I even asking for today. So as you can see, it would be really hard for me to hang up a shingle and put up a shop giving anesthesia under independent practice when I can't even order the drugs to deliver said anesthesia. The 1994 law replaced anesthesiologists with the term duly licensed physician, and that resulted in the surgeon taking on this direction and responsibility when an anesthesiologist is not present. These surgeons have little to no training in anesthesia, and they don't want to be responsible for the actions of another practice. And when a doctor or their contract lawyer sees the word responsibility, they immediately think liability. Lastly, I want to talk to you about two very different Georgias today. There is the Georgia of the urban areas with all their trauma centers, their large hospitals, and their specialists. But I can tell you from personal experience of practicing in Hawkinsville, Georgia, it is very, very different there. CRNAs like myself are filling the gaps in rural Georgia of these underserved areas and communities that anesthesiologists unfortunately priced themselves out of years ago, which help further create these healthcare deserts that we are dealing with still today. HB 445 will update this burdensome law with a very easy to understand rule that lets CRNAs go to work with a surgeon when the surgeon says it is time and gives us an order. I look forward to your questions. Thank you.
Okay, let's hear someone that's in opposition, hear a different view. Who do you want, Jet Tony? Oh, excuse me. Do we have a question first? No, okay. Who wants to go? Jet Tony, would you come up and speak?
Yes, sir. Mr. Chairman, do you want her to remain or do you want her to step out?
You probably step out because he's going to need to sit there. Thank you.
Mr. Chairman and members of the committee, Jet Tony, representing the members of the Georgia Society of Anesthesiologists. And Mr. Chairman, may I ask a question? Are we referencing the original bill or a proposed substitute? Because
we've got a substitute, LC 339461S. Is that what you're speaking from, Representative Lathier?
Yes. Yes, sir.
Yeah.
Okay. So, Mr. Chairman, I'll pivot a little bit along the way because this proposed substitute, I think, has some difficulties in it that probably are unintended. So, I represent the Georgia Society of Anesthesiologists, and the mission of the GSA is twofold: to provide world-class continuing medical education and to advocate for safe anesthesia and perioperative care of patients. GSA members fulfill the educational goals through volunteer leadership. Meeting the advocacy mission, protecting patients, however, requires your help and action, and that's why we are testifying today. For the reasons expressed in the testimony to follow, GSA members respectfully ask you to vote no on House Bill 445. Anesthesia care is delivered in 3 ways in this state: an anesthesiologist, a physician specializing in anesthesiology and perioperative care, administering anesthesia, or an anesthesiologist medically directing up to 4 anesthetists simultaneously, a certified registered nurse anesthetist working under the direction and responsibility of a physician, dentist, or podiatrist. In each of these scenarios, a physician is materially involved in the care of the surgical patient. This is current Georgia law. You've heard it in testimony. It has protected patients since 1994. It is protective of patients throughout the state, regardless of where the surgery or the procedure is being conducted. House Bill 445 incentivizes, as some say, the removal of physician participation in the continuum of anesthesia care. And that, simply put, is going backward as healthcare policy. No progress or expansion in healthcare occurs when physicians are removed from medical treatment. Not in Atlanta, Middle Georgia, North Georgia, or along the sparse stretches of South Georgia. Anesthesia is serious medicine, and Mr. Chairman, with your permission, I'd like to introduce Dr. Amanda Brown.
I'm sorry, we only have 5 minutes left. We're going to lose a quorum.
Okay.
And we have a question.
All right.
Go ahead.
Thank you. Thank you for your testimony. I know we have a list of hospitals and surgery centers, plastic surgeons, orthopedics, and different ones who use CRNAs in that 3rd level you mentioned, where overseen by a duly licensed physician, and frankly at some of the smaller hospitals that are listed. When the physician is part of the anesthesia care team, when they are in co-responsibility, so to speak, with a CRNA, is it your belief, or do you know if the surgeons consider the degree of illness of the patient, the likelihood of comorbidities and complications as part of that anesthesia care team, not just the mechanics of a procedure, but don't they consider the patient's risk as being part of the anesthesia team, not not the sole person providing anesthesia. Do you think that physicians at all these places that are now supervising CRNAs, they're overseeing the anesthesia care and have some responsibility, do you think they take that into their risk evaluation of whether a patient's safe to be done in a surgery center or should be done in a full-fledged hospital?
Well, they certainly should, and what Dr. Joe Sharma, who testified on the Senate side on this bill, would testify if he could have been here today. He would say that surgeons ought to be in charge of the full care of their patients, and with collaborating with the anesthetist, whether it's an AA or a CRNA, to make the decision about whether the patient is well enough to have that particular procedure on that particular day.
Thank you. That's what I see as an advantage of the team approach that we have now. I really don't want my surgeon or my wife or a mother-in-law's surgeon to have no care, no consideration any more than just writing an order. I really want them to think long and seriously about the risk that my family member would have at a surgery center for a procedure that might be safe for one person but maybe not safe for another. Thank you for your testimony.
Thank you.
Yes, sir. Thank you, Mr. Chairman. And I thank everyone for their comments and statements about this legislation. But my question is to the author of the bill. I heard you mention, I'm sorry. I'm sorry. I gotta yield. I gotta emergency.
Thanks, Chairman. I just got a quick question, and really just not knowing that much about, but pursuant to an order, I mean, my question is, can't an order be very specific about what that physician wants to have done? I mean, I don't know. I mean, is it
That's a good
just some kind
question.
of standard thing that an order
Good question,
is?
Mr. Parsons. I don't know.
Okay.
But I do know that an order is defined elsewhere in Georgia code.
Okay.
And it doesn't, I don't think that definition covers what is intended by the author in this legislation.
Okay, thank you.
It's my understanding, too, that the CNRA is responsible from the time the patient is being prepped to the time the patient is awake and whatever time prescribed after anesthesia. I'm not a medical doctor, so Megan, you're going to have to help me here. Give you an example, when I had eye surgery, I had to stay in the center for X amount of time after because of the anesthesia that they used. So the CRNA is responsible for that time element from beginning to end. The surgeon is gone. Their duties are done.
Yeah. Okay.
Am I correct?
Yes. So, from what I understand, first of all, the question is about having the CRNAs involved in the discussions with the surgeon to figure out what type of anesthesia is appropriate for that surgeon, and if the procedure, if their comorbidities are appropriate for the operation today. And yes, that takes place constantly. We are in constant communications with our surgeons. Secondly, to address your question too about like an outpatient surgery, and does a patient meet discharge criteria to go home? Is that what the question is?
My question was just, I mean, I don't know. To me, it seems like instead of being under the direct responsibility or whatever of a doctor, I mean, if the physician wrote his order specific enough that it could be carried out exactly the way he wanted. I mean, if that CRNA did what the order said for them to do, it would be the same thing as if he were watching and observing. I think that's what I'm trying to figure out. How specific can an order be?
It can be as specific as the operation or the patient's comorbidities need it to be. Again, we are in constant communications with our surgeons. A surgeon would see you and say, hey, yes, you have a rotator cuff tear and you need to have surgery. And based on your health status, we would decide together if that's a good option for you to be having that surgery at a larger hospital if you have multiple comorbidities, or if you're healthy enough to undergo that procedure at an outpatient surgery center. And then from there, if you had risk factors that made you at risk, that put you to where maybe we didn't do a certain shoulder block for you because of lung issues, then we would let that surgeon know. And so the surgeon is involved in that care and that decision-making process.
Okay, thank you.
Yes, sir.
Representative Jaspers, is your light on? Sharper, Representative Sharper.
Thank you, Chairman. All right, I'm just going to give a quick, so I can understand this, okay? Let's just say I'm a physician.
Okay.
Do BBLs and all that kind of stuff, plastic surgery, I do all that. All right, and I need a CNRA because I'm going to put people under, in a sense, for anesthesia. So how do I go about, do I just maybe could I hire a CRNA person to come and do the anesthesia for me, and that's all they do, and I work on what I work on and they just work on that part?
Yes, sir. That's exactly how that works. We would work together as a team to take excellent quality care of that patient. You would focus on the operation. I would focus on taking great care of that patient throughout the perioperative process, and pre-op giving them appropriate medications to quell their nausea and vomiting, to pre-treat any pain before their body experiences it. I'm not sure if you're familiar with the ERAS protocols.
Okay.
Take great care of them, put them under general anesthesia if that's what's required, or if it's a deeper TIVA sort of sedation procedure. Wake that patient up safe and sound at the end, monitor them in the recovery room until they meet your facility's discharge criteria and what I felt comfortable with sending that patient home in that state. So yes, sir, that's how that would work.
Okay, and quickly follow up on that. Now, that's in like an employee contract situation between the two, but here's my question. Now, if that CNRA, they having that responsibility and liability on them versus me, my only question is, it becomes medical in a sense, but if that BBL doctor or whatever is solely focusing on what they do and not focusing on what you do, that would be a concern for me. That would be a grave concern, because a lot of times anesthesiologists, and you probably guys do the same thing, when you have a patient, you go over the risk factors, you go over everything. But however, that is more, to me, a more medical thing and not so much of nursing. So I'm missing that part where I want that physician that is an expert in that particular field to have oversight. And with the way that y'all are presenting this, you're not really having, per se, that oversight of that specialist in that particular field. And it could be dangerous if all these different physicians that are doing surgeries everywhere, you just say, well, I'm going to get a CRNA in here and just watch them. But that medical oversight is not there. And those are some serious medicines, or you know that there's serious medicines that these people have to take. And if an emergency happens, at that point, that's another medical situation where somebody's got to know ACLS on the spot, somebody got to know AEDs, somebody got to know the emergency mode. And if that BBL doctor, if he's not, I'm not saying he don't, but he's focusing on what he does, and then it's all on you. And that's just a liability. But the way it is right
Excuse
now.
me, Representative Sharper.
Go ahead, you're good.
I need to move on to some other folks.
Yeah, you're good.
And I apologize. We're going to get a vote on this, okay?
Okay.
Thank you. Representative Cannon.
Thank you, Mr. Chairman. I'm from Southwest Georgia and understand the rural issues with physicians and nursing. We have that issue. We're trying to correct it as a community. Just recently had PCOM established there, and that's helping us a little bit. But in June, I had double knee replacement, which I don't recommend anyone having double knee replacement at the same time. But I was under anesthesia for about 6 hours. My left knee took 1 hour. My right knee took 5 hours. So I'm trying to wrap my head around the rural issues with physicians and nurses and medical shortages of personnel, but then also make sure that the properly trained person will be in the OR with me if something went wrong when I was under for 6 hours. So I'm just trying to wrap my head around that and reconcile those two issues and try to make sense of it. It's hard to do that. So maybe you can help me through that scenario a little bit better.
Absolutely. I think I can respond efficiently to both of your questions and concerns. First of all, I am a registered nurse. I went to nursing school. I have a bachelor's of science degree in nursing, and I worked in the ICU for many years, running codes, taking care of critical patients, making those tough calls in collaborations with doctors. And we are not removing doctors from this. There is still an operative surgeon involved. Secondly, my number one job when you are asleep in front of me is your safety and to be your voice and a voice of concern when you are not able to speak for yourself. We are all, in response to your question, we are all ACLS, Advanced Care Life Support certified. We have BLS, Basic Life Support, and then we also are PAL certified, which is Pediatric Advanced Cardiac Life Support. So if something were to go wrong, I would want me to be there taking care of me, or someone like me to be taking care of me, because that's exactly what my foundation of my knowledge is. Yes, sir.
In all fairness to the other side, thank you. In all fairness to the other side, does anyone have a question for our member down here, Jet Tony? No questions, Jet Tony. Are we still asking questions?
I had a question for the author, though.
Okay. Well, I've got, yeah, go ahead.
And I guess
Representative
this is
Neal.
really for both of you, but it comes off of what you described, that approach on the shoulder. Isn't that a description, I guess, isn't that a description of what's going on right now under the current laws in Georgia? That team approach that you described, where you and the surgeon would work together on assessing the patient, and the surgeon cares a lot because they have a vested interest. They may even have some liability, which I don't know that I don't know that taking away that liability is a feature. I think that's kind of a feature of the current system, that the surgeon feels responsibility. But isn't it clear now that if something goes wrong, if something needs to be transferred, isn't the surgeon, for lack of a better term, a higher trained, more training, and is in charge of making a decision about transferring a patient to somebody like me in an emergency department? Isn't the surgeon in charge of that, or do you know, Jet? Or
Well, under the current law, the surgeon is responsible for direction of the anesthesia care plan.
And the surgery.
And the surgery in collaboration with the anesthetist, again, whether it's CRNA or an AA.
I think you described an excellent team approach that's going on right now. I applaud you for what you do and the way you work in a team now. And I just really appreciate the system being team approached under our current law.
Okay, listen, thank you. We're going to have to wrap it up now because we're going to lose some folks. We said 5, we're already after 5. So do I hear a motion on this bill?
Move to pass, Mr. Chairman.
Second? All those in favor?
Aye.
All those against?
Aye.
Well, let's do a show of hands. All those in support of the bill? Five. All those against the bill? Nine. Okay. Unfortunately, Representative Maziak, you did not get your bill. I want to thank everyone for coming today. I appreciate your